Good morning, guys. I'm here today with Kevin. He's one of our day shift RTs at U of L. He's super smart. If you've never met him, he's a great resource. We're going to just go over a few things as far as ventilation and respiratory stuff, and then we're also going to cover ABG interpretation. We will very likely have a respiratory part 2 later on, and it will include a little bit more information as far as clinical information and how it affects the patients. This is more just ventilator modes and, like I said, ABG interpretation. So we're going to get started just by talking about oxygenation versus ventilation, and Kevin and I will kind of go back and forth on different topics, but I am going to let him go ahead and take it away and start by talking about our ventilators and a little bit about what's on the screens.
So if we're going to talk about our ventilator screen, the things that we're going to want to be cognizant of are settings down here. We have our set rate, our set tidal volume, our set FiO2, and set PEEP. This is what we choose to set up at the beginning of the ventilator setup. And we come up here and we can look at to see what our patient is actually doing. So this is how many times our patient is breathing, our exhale tidal volume, our minute volume, our relative airway pressures, and our IDE ratio. You want to make sure that your exhale tidal volume is that or more of what your set tidal volume is, and then you can tell if your patient's breathing over the ventilator, see how compliant their lungs are looking at their peak airway pressures. And we can break it down into oxygenation. We can look at our FiO2 and our PEEP for that. Those are our controls for our oxygenation. And we can look at our controls for ventilation. That's our set rate and our set tidal volume. It gives us a set minute volume, and that's how we remove CO2 from the blood. If you want to talk about vital signs, look at your oxygen saturation and your end tidal CO2. Those will be very pertinent vital signs in regards to respiratory therapy.
And then here is the other ventilator that we have in the hospital.
That's just the 980, just the big brother form of it. Again, down here, you're going to have your settings, your set rate, your set tidal volume, FiO2, and PEEP. And up here, these can all be changed as well. Coming from over here, that looks like your set, or that's your total rate, your total minute volume, your peak airway pressures. And again, you can change those more readily on the 980 to be whatever you want.
Perfect. Thanks, Kevin. From here, we're just going to go into a little bit of ventilator settings. So before we get to the modes, I think it's important to just kind of hit all of the different components that are important to understand about the ventilator. Like Kevin talked about, oxygenation versus ventilation is really important to understand, mostly just because these different settings break down into different categories. So you can see over here that in our oxygenation category, we have our PEEP and FiO2. And then down here in our ventilation category, we have our rate and our tidal volume, which are all different components of our ventilator settings that kind of make up the mode that we're giving the patient. So I'm going to let him take it away and just give a brief description of what these things are. We'll talk about them in a little bit more depth when we go over the ventilator modes.
So PEEP is your positive end expiratory pressure. That doesn't allow your lung to completely deflate at end of exhalation. That's what keeps your lungs open. Your FiO2, that's your fractional inspired amount of oxygen. That's your oxygen percentage. Normal room air is 21, so you can look over here to see how much is set on the ventilator. Your set FiO2 and set PEEP will be there. Your ventilation, that's how we control the removal of CO2 from the blood. That's determined by your rate and your tidal volume. Based on your tidal volume is going to be based on your ideal body weight in milliliters. And then we can talk about pressure support. That's a setting on the ventilator that assists the patient in overcoming the resistance of the ET tube and the dead space of the ventilator circuit, and that's for only spontaneous breaths. We can talk about our flow a little bit. That'll help determine our IDE ratio, and that is how we deliver the breath to our patient.
Alrighty. Sabrina put together this PowerPoint. I forgot to say that in the beginning. It is so much wonderful information, so a big shout out to her for doing that for us. All of these modes of ventilation are also on here on the PowerPoint side. I did break them up a little bit differently. I thought that it was helpful to think of them in just a little bit of another way. So I have here the different modes of ventilation. We're going to talk about them in categories of assist control, SIMV, and then CPAP or spontaneous breathing. So I will, again, let Kevin take it away here, and we're just going to kind of go in depth to the different modes of ventilation that our patients can be on.
So in assist control, you can have a assist control volume control. You will have a set rate, a set tidal volume, a set FiO2, and a set PEEP. The patient can breathe however much they want. If they breathe over the set rate, they are going to be delivered the tidal volume that is set. In pressure control, you're going to have a set pressure to deliver to the patient to get a desired tidal volume. You're going to have your set rate, your same FiO2, and your PEEP will apply there. When it comes to volume control plus, that is a flow setting on the ventilator. We will have a set tidal volume, but the ventilator is going to deliver the breath with a variable pressure from breath to breath to help minimize peak airway pressures and to help with the synchrony between your patient and your ventilator.
So I thought this was really helpful in how he broke these down and explained them there. Just to kind of reiterate, your volume control is when you're giving your patient a set tidal volume. It's in milliliters, which is the amount of volume we're giving the patient. So we're focusing on the size of breath that we're giving them versus the pressure control mode, which again, we're still in assist control here. But the pressure control mode, where instead of giving the patient a set tidal volume on the ventilator, we're saying we want to give them a set pressure. This is beneficial, and correct me if I'm wrong, Kevin, with patients that are a little bit less compliant from a lung standpoint.
Totally.
Maybe they have stiffer lungs, or they have pulmonary hypertension or something that's causing their lungs to be less expansive than a normal healthy person. So by controlling the pressure, we deliver the patient's breath through the use of pressure control, and then it will inversely basically give them a desired tidal volume.
Right. As a therapist, I'm always going to be concerned with somebody's relative airway pressures. I'm always going to be looking at their airway pressures to determine how much pressure I need to get the set tidal volume, because that tells us all about the compliance and elasticity of the lung at that moment in time.
Yeah, and I mean, for those patients who have a decrease in lung compliance, it's so much more comfortable for us to give them the breath with a variable pressure versus slamming them with a 500 cc amount of
at a
tidal
set
volume.
flow rate, because that set flow rate isn't going to change on assist control, volume control, or pressure control. It changes on VC plus to help with that synchrony and to help the patient just take in whatever they want.
Exactly. So that kind of brings us back down to this third one here, the VC plus. So the AC volume control is when you just give the set tidal volume. The AC pressure control is when you give the set pressure, which inversely delivers a tidal volume amount by setting the pressure. And then the last is the AC VC plus, which is a little different because it's kind of both of them mixed together. You set a tidal volume in the ventilator, so you basically say, I want the patient to receive 500 cc's of tidal volume, but you also will determine and set the pressure so it will vary, like it says here. The pressure and flow will vary from breath to breath, meaning if maybe the patient has a variation of lung compliance, sometimes it may deliver more or less pressure to achieve the desired tidal volume. Is that right? Okay.
Yeah.
So now we're going to bump down to SIMV.
And when it comes to SIMV, all of the same settings apply to assist control, volume control, pressure control, and VC plus, but we add a pressure support setting into this, and that pressure support setting is going to go into this blank space over here on our ventilator, and that is going to be a set pressure basically, and that's going to help the patient overcome the resistance of the ET tube and the circuit of the ventilator. So it's just one more added setting into there. You're going to have the same settings, your same set tidal volume, rate, FiO2, PEEP, and then you add in pressure support. And then on pressure control, you'll have your set pressure, FiO2, rate, PEEP, and then again pressure support.
VC plus is the same. So he really went in depth on the AC modes. The SMV, like you said, are exactly the same. Just with that pressure support. So the way that I kind of think of this from a nursing perspective is, with any AC mode of ventilation, if the patient begins to initiate a breath, the ventilator is going to give them whatever is set, being the pressure control, the tidal volume, whatever it is, we're going to deliver all of it. With SIMV, they have the pressure support, because if the patient initiates a spontaneous breath, they can take the full spontaneous breath. So AC, it's initiated, we give it to them. SIMV, we let the patient take their own spontaneous breaths on top of whatever the set ventilator mode is. So we give them a little bit of pressure support just to help them take that spontaneous breath. And then lastly, we're going to pressure support.
Yeah, we'll talk about pressure support. Another one is CPAP. That's spontaneous breathing. You set your PEEP, your FiO2, and your pressure support. And again, your relative tidal volumes are going to be, they're going to go with how set your pressure, like how much pressure support you're set it to your patient. If your pressure support set at 7, it's going to be less of a tidal volume than as if opposed to pressure support being set to 20. You're going to have more of a tidal volume being delivered with that higher pressure.
Yeah, we're helping the patient more the higher our pressure support goes. So this is obviously our weaning mode of ventilation. We put patients on CPAP or pressure support to try and get them off the ventilator to just kind of see if they can breathe on their own. So you're not going to be extubating a patient, like Kevin said, on a pressure support of 20. I mean, that's way too much assistance that we're giving them. You want a lower pressure support with them still having the ability to take a good tidal volume, which indicates to us that they really don't need a ton of help. They can mostly breathe on their own. Again, like I said, Serena did a wonderful job of putting all of this together. It's just a little bit more in-depth information, so please feel free to look through it. Caitlin did send that out to us via email. She does also go in more depth than I'm probably going to, just on other modes of oxygenation that our patients can receive other than ventilation. So not all of our patients are intubated, obviously. She goes into information on high flow nasal cannula, which is just kind of an in-between. You know, if your patient's needing more oxygen requirements or assistance than just a regular nasal cannula, you can put them on high flow, and it just provides them with a little bit of pressure and a little bit higher level of oxygen. So feel free to reference those slides for more information. A non-rebreather mask, really the only time from the nursing perspective we use these, which Kevin can probably speak to if we use them any other times from a respiratory standpoint, is if a patient most likely needs to be intubated or is requiring a very high amount of oxygen. This is kind of an all or nothing thing, which is really the only point I want to touch on. So your patient's not going to be on 5 liters non-rebreather. It's either 15 liters or off. You can wean them from a non-rebreather to a different mode of oxygenation, but if you're on a non-rebreather, they're on 15 liters, and basically the next step from a non-rebreather is intubation.
You need to keep that bag inflated on the non-breather. If the patient is inhaling and that bag is shutting, you need to increase your flow more. That's the main point that I want to say. A non-breather, use it in the case of emergency. If something happens where your patient's sats decompensate to the 70s or 60s, put them on a mask in the interim.
Perfect. Yeah, that is helpful. So if you guys have ever used a non-rebreather, you'll see when, like Kevin said, when you hook it up to the oxygen flow meter and turn it all the way up, that bag inflates. So that's a good point. If the bag's not inflated, then it's not working. Same thing, a little more information on non-rebreather. For Venturi masks, this just gives you a more accurate percentage. So you can kind of set the amount of oxygen flow and percentage of oxygen.
The Venturi device is going to deliver FiO2s between 28% up to 55%. These are going to be your travel pieces for your trach patients. Respiratory can help set that stuff up if you need to, assistance, because you are going to have a couple of different devices to piece together. And on those devices, it's going to tell you the relative flow rate that you will need to achieve the FiO2 that is set.
Absolutely, and that's the point that I wanted to touch on with Venturi. RT really will be a huge assistance in helping get patients on these that really just need to be on a Venturi mask, but we mostly use these for travel. So if you have a patient that's on a trach mask and they have to go down to travel, you can see all of the pieces of the Venturi in here in this picture, which is really helpful. So when you get the mask out of the Pyxis, it will look like this. What you have to do to travel with it is take off this little blue accordion piece, which you will see the patient has one of those on their trach mask. So you'll take off this blue accordion piece. You will then, this end that was going to the mask will actually attach to the patient. This end attaches to your oxygen cable down here. So you'll pop this little plastic piece off, and what you'll do is you'll pick either this blue or white piece, they've got a bunch of different options here, but we have a blue one and a white one at U of L. And then we have this other little white adapter piece. So basically the blue portion has lower levels of oxygen on it. The white piece has higher levels of oxygen on it, meaning, 8 liters of oxygen at, 45%, for example. So depending on the oxygen settings that your patient is actually on is the piece you'll choose. So find the one that most closely matches up to what your patient is on. If it doesn't directly match up, meaning your patient is on 10 liters of oxygen at 45%, then choose the option higher. So say you were on 10 liters at 45% and your only options on the white piece are 8 liters at 40% or 12 liters at 50%, you want to choose the higher option for traveling. You just click the white piece or blue piece then together with that additional white piece. I hope this makes sense. And then you kind of plug those two things, that thing between your two pieces here. So your blue accordion piece will attach to your little plastic piece that has the set amount of oxygen on it, and that will attach, this little end piece here will attach to the oxygen. And then the opposite end of the tubing there will just attach to your O2 tank. If you guys want us to actually show you how to do this, we're happy to, and like Kevin said, RT can help you set it up. I'm not going to go over nasal cannula. We went over how to set up a trach patient that needs to travel. Sabrina has alarms on here as well. I'm not going to get into that too much. We will go over a little bit of helpful tidbits as far as troubleshooting your vents, which I'll go over in just a second. And then I'm going to have Kevin go over weaning parameters and just cuff leaks very vaguely. I know that night shift doesn't get to see a lot of weaning parameters at night. So just a few little helpful tidbits as far as alarm and troubleshooting goes. There are different alarms. There's a low level, medium level, and high level alarm. Obviously, if your patient is high level alarming, you need to go into the room just to see what's going on. So if they're high level alarming, a few different things could be happening. So from a nursing perspective, as far as troubleshooting, the first thing I do is, one, make sure my ventilator is connected. Sometimes the ventilator circuit can break, or if the patient is trached, they can kind of pop themselves off the ventilator, which would create a high level alarm, just telling us the patient's not getting the volumes and the mode of ventilation delivered that they're supposed to be. So initially I just troubleshoot all the tubing and make sure everything's connected. Then I suction. So if you have any kind of occlusion in your circuit, it'll give you a high level alarm. If the patient has a mucus plug, or just mucus in general, if they have a clot, any kind of occlusion will give you a high level alarm. So suction your patient and see if that helps. Additionally, provide them with a little extra O2. You can hit that 100% button before you suction and just make sure that you're hyperoxygenating them while you're troubleshooting your circuit. Next, make sure their bite block's in place. So I think this is an easy one for us to miss just because we don't really mess with the ET tube that much. That's more the RT's role. But sometimes if your bite block slides out of place and your patient's chomping on their tube, it will decrease the amount of space that volume can be delivered. So it'll create a high level alarm. So make sure they have a bite block in place, and you can always put an additional bite block in place. And then lastly, sedation. If our patients aren't sedated appropriately, they can cough a lot, they can gag a lot, just anything that's going to increase their intrathoracic pressure is going to make it harder for them to ventilate. Do you have any other tidbits, Kevin, as far as troubleshooting?
Yeah, go in and see what's going on with your patient. That's the big thing. Like, alarms, the do-do-do-do-do.
Ooh, a little singing.
Yeah.
And then just call RT. But, before you call RT and make them run all the way across the hospital to suction your patient, just troubleshoot and see if there's anything that we as nurses can do before we call RT to help us troubleshoot.
I, as a therapist, I'm going to look for leaks in the system, see if there's a leak anywhere distal to the patient or proximal, and then suction the patient, see if there's anything occluding the airway. It could be mucus plug, could be blood. Think about bronchospasming. That could be a thing. Give them treatments for that. Think about bite blocks being displaced. Bite blocks can occlude pilot balloons, which can cause an artificial leak. Think about the fishhook bite blocks that go actually between the teeth. Those things can also help alleviate pressure on the system. And then sedation, it wins.
Yeah, it wins. Make sure our patients are sedated. I'm going to let Kevin take over on weaning parameters. Sabrina does have a lot of information on here as far as weaning parameters go. Just kind of the high points he's going to cover.
Yeah, so weaning parameters, like when I come into work, that's my job, get somebody off the ventilator. I'm going to look at their level of sedation to see if they're awake enough to even participate. That's when it comes in working in conjunction with you guys as nurses, and that's where like our rapport is built. Because I'm going to go in while you guys are getting report, piss your patient off, and then say, hey, we need to extubate them. It's a great morning. I want to see what their sedation's like, and then I'm going to look at their ventilator settings to see if they are on high PEEPs, high FiO2s. If they're sedated and on high PEEPs and FiO2s, they're not getting extubated. If they're on minimal sedation and they're arousable and they're on low FiO2 and low PEEP, let's put them on pressure support, see what they can do spontaneously breathing on their own. I will then look at NIF, a negative inspiratory pressure. That tells me how strong their diaphragm is and if they can take in a strong breath, and then I will make them do a vital capacity maneuver, make them take a big deep breath in and blow it all out. That can tell me if they can cough afterwards. If I'm worried about their airway being compromised and irritation and swelling going on in their airway, I'm going to definitely check a cuff leak. We want to make sure that there's not going to be an immediate cost to re-intubate them. If we can look at that and assess it beforehand, we can treat them with Decadron beforehand or some other form of IV steroid to help decrease the inflammation in their airway. And then if all those things are great, pull the tube. Let them breathe on pressure support for about a half hour in the morning. Some physicians will ask for a blood gas while they're on pressure support, but if the patient's awake enough to like converse with me, do the mechanisms that I need them to do, I'm going to pull the tube on them.
Absolutely. And then just for number purposes, so you want your RSBI to be as low as possible, correct?
Yeah. Think of the name Rapid Shallow Breathing Index. It's indicative. If your patient is breathing fast and shallow, do you want to eliminate the support that's already being given to them? No. You want your patient to be taking decent tidal volumes relative to their ideal body weight between 5 and 600, and you want their rate to be slow, nice and even.
Absolutely. Slow, deep breaths. NIF, I believe we look for less than negative 25, is that correct?
Negative 20.
Negative
so
20.
You want your NIF to be more negative. So if it's negative 10, that's not good. The more negative it is, the better. So if it's negative 20, great. If it's negative 40, outstanding. That tells me that their diaphragm is intact.
And then, like you said, they check for a cuff leak. That's just either positive or negative. They have it or they don't. And then they check the patient's tidal volume. So what would be a good? I guess that's more dependent on the patient's actual size and their ability to take a breath. But the bigger the tidal volume, the bigger the breath, the better.
Yeah.
Okay. I think that's pretty much it with weaning parameters. And the RTs are such a great resource. I mean, they get all those weaning parameters. They call the physicians and tell them the weaning parameters. So they pretty much kind of know what's going on there. But it is helpful just to understand what is going on as far as the weaning parameters that we're obtaining. Lastly, guys, I think we're just going to go over ABG interpretations. Actually, let me back up. I do want to go over ARDS really quickly. This is very, very quick, just a small touch on this. The COVID patients, I have heard, present similarly to ARDS. Now, small disclaimer, we don't know. We don't know. There's so much unanswered questions about this disease process, so take this with a grain of salt. I just wanted to very briefly cover ARDS. We're not going to go into the pathophysiology a lot. I'll have another lecture more in depth on respiratory stuff. That's our respiratory and mechanical ventilation part 2. But I thought this was a helpful tidbit, especially because the trauma physicians do not usually know this. And Kevin can speak more to it as well. But if you have a patient that's in ARDS, they have a decrease in lung compliance. So as a nurse, one of the things that I will typically do in collaboration with respiratory therapists is calculate the patient's PF ratio. So all you do is you look at their blood gas from the morning and you take their PO2 and you divide it by their FiO2. So whatever the patient's PO2, which you want to be greater than 80, whatever that is, you divide it by their a percentage of oxygen that they're on, and that will tell you a number. I always have to pull up the chart, but there's a chart, and I can attach it in the comments that says, basically if the patient is in early stages or not very severe ARDS, kind of in the middle, or very severe ARDS. So it looks like, Kevin's drawing it out for me. It looks like anything over 200 as far as...
I think it's less than 200, you're going more so into ARDS.
Okay.
And if it's like 300 or greater, you're more of like, or like that 500 mark, you're like acute lung injury phase. So the smaller that number gets, the more closer to ARDS you are.
Wonderful. So the smaller the number, the worse you are in ARDS. The larger the number, you're not really in ARDS. The only thing which the respiratory therapist will do this, but it is helpful for us to know, is that when your patient is starting to go into ARDS, their chest x-ray looks terrible, it's consolidated, they have a really low PF ratio, you need to have a high PEEP. So basically the way that the alveoli work, they're collapsed in ARDS. And if you don't open them up, the blood that passes through the lungs isn't going to partake in oxygen exchange. So you're not going to be able to oxygenate the blood that's passing through your pulmonary system if your alveoli are collapsed. So you want a higher PEEP in ARDS patients. You want a lower tidal volume. Again, their lungs are so stiff and non-compliant. If you're hitting them with a huge tidal volume, it's not going to benefit them. So you need to pop open those alveoli, decrease their tidal volume, and increase their rate. If we're not giving them as big of breaths, we want them to breathe a little more frequently to make sure that they're partaking in appropriate oxygen exchange.
Yeah.
Much of it.
Yeah.
And then lastly, pronation. So moving those patients and again popping open those alveoli and mobilizing secretions as much as possible is really going to help with oxygenation and ventilation. So rotoproning, we can do manually proning, or even just rotoresting and turning them drastically will help their outcome with ARDS. Okay, next we're going to do ABG interpretations. This is a super helpful, very in-depth PowerPoint. Again, please feel free to reference it. I will try and post both of these on the Facebook page for your all's reference in addition to the video. I'm only going to cover today, just for time purposes, a few slides of this. So Kevin and I are both going to explain our take on ABG interpretation. They're slightly different, both correct, but I think that depending on the person who's listening, one may be more helpful than the other. So starting off, we will come back to ABG values when we do the interpretations. I'm going to let Kevin just kind of hit really quickly on this compensating organ slide because it's really helpful.
Okay, so our lungs and our kidneys are going to work in conjunction to keep our pH in a normal level. Our kidneys are going to help buffer our blood if it becomes acidotic. They're going to secrete bicarb into our blood to help with that. It's excreted through our urine. The kidneys are slow but effective. If I was a therapist, I'm going to think about what our nursing staff can do to help with this in terms of like giving our patient bicarb or looking at their kidney labs and looking at their kidney functions to see if their kidneys are actually helping compensate at all. Our lungs hopefully will not fail in removing CO2 from our system because that's a primary compensating factor for our pH. So we get rid of CO2 by exhaling it out of our lungs, and yeah.
Pretty much covers it. So the nice thing about these compensating organs is just basically, I mean, we'll talk about this more, but if your patient is acidotic or alkalotic, our body typically in a healthy patient will compensate. So your kidneys obviously assist with bicarb, and then your lungs assist with the CO2. So those two things can drastically affect our compensatory mechanisms. So if you have a patient in acute renal failure, you're not going to be able to compensate and regulate your bicarb normally.
And same goes for if they're in respiratory failure, you're not going to effectively remove CO2 from your blood to help compensate for your pH.
Absolutely. And that's when you'll see, as we're about to talk about, if it is a respiratory or metabolic issue with your alkalosis or acidotic state. So just really quickly, we'll leave this slide up while we talk about this. Your normal ABG values, your pH is going to range from 7.35 to 7.45. Your CO2 between 35 and 45, and then your bicarb from 22 to 26. Another important thing on your ABG is your PO2. So is your patient oxygenating appropriately? We want that to be greater than 80. So really your FiO2 is a big factor on the ventilator that can change that.
Your FiO2 and your PEEP are going to be your controls for this. Your PO2 right there.
Absolutely, which makes sense because your alveoli is where gas exchange and oxygenation occurs. So if your alveoli are collapsed, and that's what your PEEP does, is just pop those alveoli open. So I'm gonna take a stab at this. My explanation is obviously a little more lengthy and wordy just because I'm a big talker. So the way that I usually explain to either new nurses or students that are with me ABG interpretation is kind of like this. So it's hard to do this without being able to physically draw and show you, but I'm going to do my best. When you have a patient who's ventilated, we will usually get a daily blood gas. And when I look at my ABGs, I like to interpret these every morning while I look at my labs. So the first thing you have to do is determine whether or not your patient is acidotic or alkalotic. So looking back at your pH range, acidotic is going to be a lower number. So less than or equal to 7.35, you're going to be in an acidotic state. Alkalotic is going to be higher. So 7.45 and up, you're going to be in an alkalotic state. Once you determine if your patient is in an acidotic or alkalotic state, you have to figure out if the origin is metabolic or if it's respiratory. So let's start with acidosis. If your patient is acidotic, meaning your pH is low, you are either going to have an elevated carbon dioxide or CO2 or a decreased bicarb or base, HCO3. Those are the only two things that are going to cause an acidosis, an elevated CO2 or a decrease in bicarb or HCO3. And once you figure out which of those it is, that lets you determine whether it's metabolic or respiratory. So in your acidotic state, if your CO2 is elevated, it's respiratory. It's a respiratory acidosis, plain and simple. If your base or your bicarb is low, very, very low, and your CO2 is normal, then it's a metabolic acidosis. So once you determine which of those two values is really kind of out of whack, your CO2 or your bicarb, you can determine whether it's respiratory or metabolic acidosis. After you determine which is your cause, the next thing I do is look at the opposite value, meaning if we have a CO2 that's very elevated in an acidotic patient, I'll say, okay, my patient is acidotic, my CO2 is very high, they're in a respiratory acidosis. I will then look at the bicarb to see if it is outside of the normal range to determine whether or not the patient is compensating. So if your patient is in, again, a respiratory acidosis, your CO2 is really high, your pH is really low, you've determined the respiratory acidosis is the cause. If your bicarb is really, really elevated or slightly elevated, your patient is trying to compensate by increasing their bicarb in their body. So that would be a patient that is in a partially compensated respiratory acidosis if the pH is not within normal range. If you have a respiratory acidotic patient and their pH is within normal range and their bicarb is still slightly elevated, they would be a fully compensated respiratory acidosis. I hope that makes sense. Basically, like I said, you're just looking at the blood pH level, determining acidosis, and then you either have a decrease in your base or an increase in your CO2 drastically that's going to cause either a metabolic or respiratory state of acidosis. The opposite value, if it starts to kind of creep out of that normal range, will determine whether or not you're in partially or fully compensated state of whatever you're in, respiratory acidosis for example purposes. When we get to alkalosis, it's the same thing, very similarly. You have a patient that has a very high pH, so in this case, you're either going to have a decrease in CO2 or an increase in your base. So if you have a patient that has a very, very low CO2, they're going to be in a respiratory alkalosis. They have a very high bicarb or base, they're going to be in a metabolic alkalosis. Again, just quickly, it functions the same way. So I'll look at my pH, it's high, I know they're alkalotic. I'll look at my CO2, we'll say for example purposes, it's low. So they're in a respiratory alkalosis. I'll then look at my base to see what's happening. So if my base is lower outside of my range of 22 to 26, they're compensating. So then I'll know that the patient is compensating for the respiratory alkalosis, and depending on whether or not the pH is within normal range, I'll know then if they are partially or fully compensated. That's all I got. I'm going to let Kevin take it away and give his explanation.
So I like to think about the blood in terms of pH. If you want to think about it, like if you're acidic, you're like orange juice, and if you're basic, you're like milk. And how can we keep our blood relative in between both of those things? And our kidneys and our lungs are going to help keep your pH normalized. And if something goes wrong with either of those two systems, the other should help compensate for it. So our pH and our CO2 are going to have an inverse relationship, meaning as our pH goes down, our CO2 will go up. And as our pH goes up, our CO2 goes down. Reversely, our pH and our bicarb have a correlating effect. As our pH goes down, our bicarb will go down as well, and if our pH goes up, our bicarb goes up. Now, I'll look at, when I'm interpreting a blood gas, I'm going to look at the pH and see if we're acidic or basic, and then I'm going to determine if it's caused by a respiratory mechanic or by a metabolic factor. So if it's a respiratory problem, you're going to have an elevated CO2. I will then look at our bicarb to see if our kidneys have helped compensate at all. That can be shown in your pH. If your CO2 is grossly elevated into the 80s and 90s, our CO2 or our pH should be 7.1, 7.0, something like that. If your kidneys aren't compensating, doing the job that they should be, secreting bicarb into the blood to help buffer the blood, it should keep it up into that 7.2 range. And if we want to talk about like a different way, think if like an alkalosis problem, think about DKA, diabetic ketoacidosis. If our pH is being driven down so much by the metabolic factors in our body, you're going to see a decreased bicarb with that decreased pH, and what's going to happen to our CO2? Our CO2 is going to be, well, excuse me, I said that wrong. You're going to have an increased pH and an increased bicarb, and our CO2 is going to be driven down all the way to what our body can physically do to help keep your pH up at that non-codable level.
I hope that those made a little bit of sense. There's one other thing that we want to touch on, which is just the base excess, which you'll see on the ABG values. So from a nursing perspective, really the only thing I use this for is if your patient's ABG looks fairly normal, you can see their base excess can help determine their fluid volume status a little bit. So if your patient, obviously a negative base excess means they're dry. A positive base excess means they're wet. This can vary based on the patient's pH too. So in a very, very acidotic patient that, could have hemorrhaged or be very, very hypovolemic, you will see that fluctuation in the base excess because of the loss of volume. But if you're looking at a fairly stable ICU patient, I will look at the base excess to help me determine, in addition to CVP and vital signs and other numbers, if the patient is wet or dry.
Yeah, just overall fluid status. It is a calculated value on our machines. I, as a therapist, will look at it to help determine if our blood gas has a metabolic factor into it or not. Any negative base excess will give you a metabolic acidosis. To what extent that is determined to how negative your base excess is. Like Katie was saying, if you're hypovolemic and you're traumatic and lost a lot of volume, that base excess will be -15 and -20. More negative it gets, the more acidotic you get.
Absolutely, which tells us that patient needs volume. They need blood. They need to be
fluid resuscitated.
Absolutely. So use that as another form of knowledge and information when you're trying to tell these physicians if your patient is either volume overloaded or volume depleted. If they're volume overloaded, their base excess is going to be 8, 10, 12, and they need to be diuresed. If their base deficit or negative is, like Kevin said, in the -15s, they need to be aggressively resuscitated. So just kind of don't forget about that number. It's really a good tool to use and something that I think a lot of the teams don't really pay attention to. I think that's pretty much all we've got, guys. Sorry this video ran a little longer. There's just so much good stuff that we wanted to talk about, and I hope that it's helpful and just helping us as nurses feel comfortable assisting with managing our mechanical ventilators. The next few weeks could get really crazy with all this COVID stuff, and we only have so many RTs in the hospital, and they're going to be stretched pretty thin, I can imagine. So if you have any questions, please comment below. Any questions we'll be happy to answer, and I have Kevin's contact information so I can reach out to him if there's anything that I cannot answer. Thank you all for listening, and Sabrina, thank you so much for making this educational material. I know you put a lot of hard work and time into it. We really appreciate you for doing that.
Thanks to everybody who cares for anybody during these times of need. We all need to work together as a team. and be there for each other.
Absolutely. All right, guys. Have a good rest of the day.